Hello, and thank you for joining me for today's episode of Big Ideas in Eating Disorders. In this series, we hear from people in the field of eating disorders who share with us their personal, professional journeys, their ideas and reflections in ways that never quite get represented in conferences and professional academic papers. I'm Kathy Pike, a clinical psychologist and professor at Columbia University, and the host of Big Ideas in Eating Disorders. Today, I'm delighted to be joined by Professor Phillipa Hay. Professor Hay is chair of mental health in the School of Medicine at Western Sydney University. She is recognized globally for her tremendous contributions to the field of eating disorders. She's past president of the Australian Academy for Eating Disorders and has served in multiple roles for the International Academy of Eating Disorders. She's also editor-in-chief, along with Stephen Towse, for the Journal of Eating Disorders. Phillipa, thanks for joining us today.
My pleasure.
So as we get started, let's begin at the beginning. When did you know that you wanted to go into eating disorders? Was there a particular moment, a particular experience that served as a catalyst for this career that you've pursued?
Surely was. I was born and grew up in New Zealand and now living in Australia. And we're going to begin at the beginning. We always begin in Australia now with acknowledging traditional custodians of the lands upon which we live, work and play, and paying our respects to elders past, present and emerging, and to very dear colleagues who've been with me on my journey through eating disorders, and pay our respect to people with lived experience who also have been very much part of my journey with eating disorders. But it began in Wellington in New Zealand when I was a psychiatry intern, and on my very first rotations, I worked for a very stimulating, inspiring mentor, Professor Anne Hall at the Wellington Clinical School. And she, on her own, had really set up the first specialist clinic for people with eating disorders in New Zealand. And it was a really, really busy outpatient clinic. It included family-based treatment at that time with a family therapist, and it included a very small inpatient unit of 2 beds. That was what she was allowed within the public service at the time. And she just said to me when I was working with her, would I like to do a research project with her? And I said, oh, that sounds interesting. And it all started there. And that was my first foray into the world of eating disorders, and we were studying bone loss in people with anorexia nervosa, which at that time was very new. And in fact, there'd been one paper in the New England Journal of Medicine. And that's what was inspiring about Anne Hall. She sort of read that paper and she thought, oh, maybe we could measure it here. And she talked to the endocrinologists in the hospital, and they said, yes, they were measuring bone density at the time. And that's where it all started in terms of my journey with eating disorders.
And when you conducted that research study, was that the first time you were doing research as well, or had you been doing other research prior to eating disorders?
It was the first time I was doing research that I was really interested in and passionate about. I must confess that during medical school, I did do some research in the holidays with a gastroenterologist who was a very superb researcher, but it was all in the lab, and it was all with pipetting things and washing bottles and things like that. And it was just not my scene, I suppose. And that's, at that time, when I was at medical school, when we thought about research, we thought about research as being laboratory-based and often animal research rather than human research, although there was obviously quite a lot of human research done as well. So I hadn't really had positive exposure to research, I'd have to say. But her research was so much sort of human-based, human-focused, and about sort of learning how we can help and change things for people living with an eating disorder in terms of understanding. Well, this study was about understanding bone loss, but obviously lots of other research around understanding treatments and understanding the phenomenology of people with eating disorders as well was something she was interested in. And it was a very early time in the DSM and in the new diagnosis of bulimia nervosa. And that was what she did as well. She started to have a look at what happened at that time when the diagnosis got into the DSM. And she was seeing a marked increase in the number of people presenting with bulimia nervosa. So she went sort of backwards, looked at her case notes backwards and then forwards. And that really underscored the importance of diagnosis and being recognised in diagnostic schemes, because prior to that, they hadn't been able to make the diagnosis, but there were some people who presented and she would have said had bulimia nervosa, but there was this marked increase in presentations. And then, of course, explosion in terms of understanding of treatments with Fairbairn's Cognitive Behaviour Therapy Manual, which he actually sent Anne Hall a copy of, and we sort of looked at it and I thought, well, this is very interesting. Let's see if we can start trying some cognitive behaviour therapy with people with bulimia nervosa. And he sent her his copy of the very original copy of the eating disorder examination questionnaire, which we sort of looked at and we thought, well, that's very long. Would we ever use that clinically? And it was, yeah, because at the time the instruments available were not really very good, and certainly not good or not very valid in terms of diagnosing or assessing people who had bulimia nervosa.
Right. As you describe this research, I'm struck by the expanse of the research, the study of bone density in patients and clinical care and improving treatment outcomes. And I think, Phillipa, your capacity to think critically along that very along the continuum of basic biology all the way to improving clinical treatments is one of the ways that you've contributed so dramatically to the field. Is there a piece of that continuum that feels more exciting to you, more interesting to you, more a part of what you are passionate about in terms of your understanding of eating disorders?
I think it would have to be the treatments. I think it would have to be my involvement in treatment trials of psychological therapies for people with anorexia nervosa, as well as for bulimia nervosa, as well as integrated treatments for people with high weight problems and eating disorders. So I'd have to say that's really what's really stimulated my passion, because that makes a difference for people. If you can demonstrate and show that both therapies are effective, but they can also inform how they can be more effective. And one thing that's really reflecting on my involvement in treatment trials was the trial with the LEAP study, where Caroline Mayer at Loughborough had taken a concept of compulsive exercise. She had developed an assessment instrument for it, the compulsive exercise test, but she'd also developed a different way of providing cognitive behaviour therapy for people with anorexia nervosa that incorporates an understanding of what drives compulsive exercise, both in terms of the drivers being to manage weight and to drive weight loss, but also the drive to regulate mood, really bringing that into the centre and core of understanding the drivers of exercise and then addressing that in the cognitive behaviour therapy manual. And I have to say, I'm a non-exerciser. I'm not someone who gets a lot of good mood from exercising, and I never really understand people who go to a gym. It's a little bit beyond
it's just not your thing.
It's not my thing. I went to a really nice school, but the school had a major emphasis on exercise and activity, and I had to do a lot of exercise at school. And one thing I thought, when I left school, I don't have to do this anymore. I don't have to run across country where I would come in sort of traipsing and last. I did manage to not have to go on the novelty races in the swimming carnival, because I could actually do breaststroke fast enough to get into the heat. But yeah, and and tennis, always at the bottom of the tennis ladder, of course. And my best friend, who we partnered in tennis, she was even worse than me. So, and I was pretty bad. So that's kind of my experience and exposure to exercise. So, but this therapy around exercise is very different. It's a cognitive behaviour therapy, and it involves, as you're aware, because you're obviously part of us on that journey, really rethinking exercise and helping people to learn and exercise in ways that are adaptive and positive for them, and not maladaptive, and not ways that drive their eating disorder. So, there's lovely vignettes in that about what's healthy, what's unhealthy exercise as well. So getting people to think again and then try out different ways of exercising. And I had a person recently, we talked about the fact that skateboarding, which has really taken off here, it's nothing, an Olympic sport now, of course, can actually be quite a sociable exercise and not so intensive, because the young people sort of hang around the park and they do their skateboard, then they stop and chat and things. So something you think of might be high intense exercise is actually not. It might actually be something you'd recommend or suggest someone might try instead of, running intensely 5-10 kilometers, etc. So on reflection, I think it's those studies, and I've been involved in other studies where we've tried out new forms of therapy for anorexia nervosa, the Maudsley therapy for adults with anorexia nervosa, the mantra that was developed in London by Janet Treasure and Eureka Schmidt. We use that as part of one of our major trials in Australia, led by Sue Byrne, where she was comparing mantra with specialist supportive clinical management, which was the New Zealand one, I have to say, and with cognitive behavior therapy, which was the one from Oxford. And one thing that's really struck me out of all that research, particularly in adults with anorexia nervosa, is the struggle to find a difference in primary outcomes.
When you started doing the clinical trials, a lot of the technologies that are available to us today that make global collaborations easy and that make the transfer of materials instantaneous. Being in Australia, just wondering what you remember from those early days of clinical trials and how you connected to the global community across the miles.
Well, we used to submit our papers by printing them and putting them in envelopes and sending them to the editor, to Michael Strober of the International Journal of Eating Disorders, and 3 months later waiting on some sort of response. So there's major differences in terms of how we interact in all sorts of ways. But in doing those treatment trials, we were able to meet, we were able to do trainings, people were able to come to Australia, or we went to England, we were able to meet together, do the trainings and do the ongoing supervision and communication amongst researchers, largely using phone at the time, telephone. Now we have telehealth and much better platforms for doing that. And one of the feedback we got, definitely from the point of view of supervision and supervising remotely, was having visual telehealth available makes a major difference to that ongoing supervision and to meetings, rather than the telephone, which was largely the technology. And we thought it was pretty good technology to be able to do several people on a phone call at one time.
A conference call, that's right.
Conference call. And they were quite expensive. And
they were so expensive. I remember some of the early trials that we did, we would have to put the conference call expense into the grant budget because it was a real expense, right? And today it's essentially free to be able to talk like this with videos. So it's a pretty amazing transformation. With all of those clinical trials, Phillipa, and work that you've done with patients with anorexia nervosa, patients with bulimia nervosa, patients with higher weight, I'm sure that you, at this stage in your career, have some thoughts about some of the ways that we think about these conditions and diagnose these conditions that work, right? What are some of the criteria, some of the guidelines that we've developed that have really improved the way we think about eating disorders, and some that don't, that from your perspective, you would change, right? That's a big idea. So I'm wondering if you can share with us some of the evolution of diagnosis that you think has really improved your ability to have the better outcomes that you described, and what you might change.
Well, one thing we know from the body of research is that there are certain tools, certain types of treatment that are helpful, and that these are often transdiagnostic. The first cognitive behavior therapy that was developed for bulimia nervosa by Fairbairn, but then he transformed that into a transdiagnostic therapy, and it became one of the leading therapies for anorexia nervosa, as well as for bulimia nervosa and binge eating disorder. And then we discovered in the treatment trials for anorexia nervosa that different modalities, different ways, different tools helped, and people had similar outcomes in terms of what the primary outcome was, which was invariably weight gain for people with anorexia nervosa. So, but people achieved that along different pathways. And in all the treatment trials for anorexia nervosa, although sometimes there's a bit of an edge or a bit of an advantage for CBT, on the whole, most people improve in terms of that primary outcome. Andrea Phillipa wrote this paper saying weight should not be a mandatory criteria for people with anorexia nervosa. And I was asked to comment. And I looked at it first and I thought, that's a very strange idea. What can I say about this? I don't think it could be correct, because it's so ingrained that being clinically underweight is part of the diagnostic understanding and criteria for people with anorexia nervosa. And then I did a bit of a rethink. I went and read what she wrote, and some of the things she was saying, I could see validity in. She was saying that it was a criterion that was often a distraction. It may mean people don't get treatment because they're not quite underweight enough to access treatment. And it may mean that the focus being on weight, when people recover weight, people think that's recovery. And so it takes away from really the concept of what is recovery and a much broader concept of what is recovery. And we know that recovery is so much more than weight gain for people with anorexia nervosa. And one of the other strands of work I've done in terms of epidemiology has been community-based studies of the general population. And one study we did was we asked people if they'd had a lifetime history of anorexia nervosa, and then we were assessing their quality of life and functional status. And there was a high level of poor quality of life and impairment of functioning in people who ostensibly no longer had anorexia nervosa because their weight was in the adequate or high range. Mm-hmm. So I thought again, and so in my commentary, I wrote that I thought there were some valid arguments for de-emphasizing weight, perhaps not taking it out altogether, but seeing it as something that might signify severity or signify some level of understanding of particular treatment needs. And really that particular treatment need is the need for renourishment. But everybody with an eating disorder needs attention to their physical health, needs attention to nourishment. We know that the physical health status of people is impaired across the weight spectrum, and there's no other eating disorder which has weight as a mandatory criteria. Mm-hmm. The other part of the picture is that we're seeing many people who are presenting with states of anorexia nervosa, but they are adequate weight. And of course, the DSM puts them in the category of other specified feeding and eating disorders. And I've just been part of a program looking at the global burden of disease. And what we're finding is that those people may have as greater impairment as people who are clinically underweight with anorexia nervosa. And Tracy Wade has had a recent review saying really the same thing, that the level of impairment, psychosocial impairment, personal suffering is similar regardless of weight. Mm-hmm. And the other part of my world or my life is working clinically. And in the hospital where I work, I also do consulting to a clinic whose focus is people with metabolic disorder and type 2 diabetes. And we've just done a study then of outcomes, of psychological outcomes from that program. And surprise, surprise, losing weight was not a variable in terms of people's level of function, level of personal well-being, or other psychological symptoms such as depression or eating disorder symptoms. How much weight they lost did not impact on that. It sort of came out of all the regressions and all the sort of, multivariate statistics that we did. It was indeed how they felt about themselves and psychological symptoms, and how their attitudes and beliefs and cognitions around weight that were the key factor, not actually how much weight there was.
So let me just see if I'm hearing that correctly. You're saying that the study with individuals with diabetes, and this was type 2 diabetes?
Yes, this is a clinic where to get into the clinic to get treatment, you are of high weight, but you have to have at least one other medical comorbidity. The most common probably is type 2 diabetes, but people may have other medical comorbidities, heart disease or liver disease. And the proportion of people who have psychological comorbidities is very high as well. Again, mood disorders, but also eating disorders. So, and we knew that. We sort of studied the spectrum and the profile. And it's improvement of those other outcomes that were not dependent on the weight loss. Yeah.
Got it. Yeah. So you can see significant improvement in terms of quality of life, mood, purpose, or other aspects that are not a function of how much weight was lost.
Absolutely. And also in levels of eating disorder symptoms as well. So that was part of the things that we were looking at.
Upon returning to the proposal that weight be de-emphasized, it sounds like your review of the literature from within the eating disorders world and from within the
weight disorder world,
right? So eating from a perspective of treating individuals who have a diagnosis of an eating disorder and treating individuals who have health conditions related to excess weight. In both cases, the weight was significant in some way of identifying these individuals, but actually really was not significant in terms of understanding the severity of their conditions or what was going to help them feel better.
Yeah.
So what does that mean in terms of how we think about treatment? Because, right, if we have an individual who is at a BMI of 13 or 15, right? And that's a weight measure. And we re-nourish that individual, we know that does have an impact on mood, that does have an impact on energy, on sleep, on reduced anxiety. So where is it that weight matters and where is it that it doesn't matter?
Well, it does matter in terms of understanding the physical consequences and the physical comorbidities that people experience with eating disorders. So it does need to be addressed, and people do need help with that. But it's not the absolute weight or the number on the scales that's so important. It's really having a more nuanced understanding of that, how long people have been at that weight, and how else is their physical state as well. So it's not just the weight, it's how the rest of their physical state. And because it's a mandatory criterion, because it becomes the sort of focus for outcome, we become very fixed on it. And we say, well, you're not getting better because your weight hasn't changed this week. And I've worked in units where, the start of every team meeting, the weights would be put up as the first thing. So I think it's shifted, it's become a preoccupation, then becomes a preoccupation for the person and for the clinicians, and gets in the way of thinking more holistically about the person and about their physical state as well. So for some people, a BMI of 15, if they've had that BMI for a number of years, and have been stable at that BMI, that is very different to someone who has just reached that BMI after a much shorter period of weight loss and is still losing weight. So I always remember, I mentioned Professor Ann Hall before, but I always remember her things she always said to me was the first thing is you need to stop the weight loss.
Yeah.
It's not so much the weight gain, but it's stabilizing things for people. And that's really the first step, not the you're needing to gain, half a kilogram a week, etc.
Right. And so this idea that the field, the professional providers of care have become over-focused on weight is an interesting one. And we've heard that from patients, right? Patients will say, it's more than just my weight, and there are other issues, and wanting to expand out, and programs being, as you say, really fixed on weight as the cornerstone of whether the individual is getting better or not. And in a way, it's understandable. It's a very simple metric, right? It's so clear and so easy to measure compared to other aspects of all the other dimensions of what it would mean to get well. But when we become more sophisticated about instead of maximizing the focus on weight, optimizing overall health, that would have implications for treatment. And I wonder, as your thinking has evolved, what has that meant in terms of rethinking how you approach your clinical care?
Well, I think I've been very impacted by a study that was led by Stephen Towles, that I was involved in a treatment trial for people with long-standing anorexia nervosa, where we used established treatments such as cognitive behavior therapy and specialist supported clinical management, but we adapted them to take away the focus on weight and put the focus on quality of life. And the primary outcome of that research trial, that randomized controlled trial, was quality of life, although we did have weight as an outcome. So I'm perhaps not saying weight should not be there, and just overemphasizing it, having it as a mandatory criteria, leads to it reaching, leads to the preoccupation with it, I think. And what we did in the treatment trial was de-emphasize weight, and the primary outcome was quality of life. And we told that to people who participated in the trial, that our interest, these therapies have been adapted, and we are interested in your quality of life. So in the specialist supportive clinical management treatment manual, when they had target symptoms, they had to have a target symptom of quality of life, something to do with increasing self-confidence, improving interpersonal relationships, something about themselves and the life and the way they interact with others had to be one of the target symptoms, because the primary outcome was quality of life. A very interesting thing happened on that trial. Although the therapies were actually not that much different, the emphasis of weight and the emphasis on quality of life led to the lowest attrition rate in any anorexia nervosa treatment trial, I think, to date. We retained people much more in the trial, and that was one of the distinctive things about that treatment trial. As in other treatment trials, we struggled to find much difference between the treatments at the end, at the outcome, and people did improve, but they didn't recover, in a sense, because these were people with very long-standing illness. And we had been asked, how many people recovered, but that wasn't the aim. The aim was to help and support and make a difference for people who are living with anorexia nervosa and have got really stuck with anorexia nervosa in a long-standing way.
It's a real shift in terms of thinking about the journey, because weight gain defines a destination. You reach a certain point, and you sort of cross the finish line, and you're in the recovered stage. Whereas thinking about quality of life, stopping the weight loss, if that were happening, because that would impact physical safety, but not focusing on weight gain, actually you're moving away from a target of a recovered state to an understanding of living in recovery, right?
Yeah.
Where you're in a higher quality of life, a stable quality of life, living in recovery with symptoms of a health condition. And there are many other kinds of health conditions that we learn to live with because
Mm,
they're not going away, right? And
mm.
can still have a very high quality of life. And
Yeah.
it sounds to me like that's a piece of what you're describing.
Yes. I mean, I think for some people, the therapy was the start of a longer journey to recovery, but acknowledging that within, 8 months of therapy, 30 sessions, that's probably insufficient time for the majority of people to fully recover in a holistic sense from anorexia nervosa. And for some people, it was really interesting. They actually went on to participate in other treatment trials. The one that I mentioned, the one led by Sue Byrne, which was more, I suppose, a more active recovery journey type of therapy that was offered. So for many, it was the start of a longer journey. And just talking about it in that way with people, saying, well, this is your journey. This is a journey of recovery. It's slow, we accept it's slow, but it is a journey of recovery, I think makes a difference, that you don't have to reach a certain point at a certain time and therefore you've failed. And we really should never underestimate the impact of that sense of people, particularly with long-standing anorexia nervosa, who feel they have failed, they've failed treatment. And I think now treatments fail them. They haven't failed treatment. You can't fail treatment. If there was something about the treatment that didn't engage you, that didn't meet you where you were at that time, at that point in your journey, then it's the treatment that's not appropriate rather than the person failing the treatment.
Yeah, big. It's a subtle distinction and a profound one. And an important one. Phillipa, as you look back over your career, back to those early days when you were invited to participate in your first research study, anything that stands out that you thought you were going to solve, right? As you're young and you think you're coming into the field and you're thinking, okay, I'm going to achieve this. I'm going to solve this problem. I'm going to make this discovery or establish this database.
Well, I do remember doing my PhD defense at Oxford with Gerald Russell, and my PhD was actually around classification and diagnosis and very sort of complex statistics, cluster analytics statistics, which were looking at people with recurrent binge eating in the community. And I came up with a different sort of view of that than the DSM at the time, not very different, but a different view. And I remember Gerald Russell smiling at me at my defense and saying he wasn't quite sure it was going to, capture and change the DSM. So one learns very early that that you do research, it's part of the piece, it adds together as part of the piece. But I think some of the research I have done around classification schemes and an understanding of actually binge eating as a phenomenon and how it's a loss of control over binge eating that's really the impactful thing for people, and the thing that really is associated with psychological distress. And the research I've done in that, which has influenced the ICD-11, but I'm not sure it influenced the DSM quite yet, to expand the concept of binge eating to include people who don't, binge eat on large amounts of food. Has been something that's happened. But you do learn that it's small changes over time, and to change things in terms of our diagnostic schemes is very tough. They tend to be locked in time. So we have anorexia nervosa, we have the DSM-3 understanding of anorexia nervosa, then we have bulimia nervosa in the DSM, then binge eating was added, which really came from a different historical background, came from Mickey Stunkard's work in people with high weight, and he really conceptualized the first understanding of what a binge is. That was what was used actually for the diagnosis of bulimia in the DSM-3, but by later versions of the DSM, really the concept of bulimia nervosa had taken hold, and binge eating disorder took many years to get into the DSM system.
Nomenclature. That's right.
So it's tough, it's incremental. And it's also, when you look at the DSM, you think, why are the disorders of recurrent binge eating so different? Why do people bulimia nervosa, why are they required to have overvaluation about weight and shape concerns? Why are they required to have a psychological understanding of the drivers of the eating behavior and a sort of core psychopathology? But people with binge eating disorder are not. It's purely on the basis of the binge. And then there's all these diagnostic specifiers of the binge that you have to have, 3 out of 5 of, but it's all about the binge. And a paper we just recently published in the European Journal with Anna Matera from Poland, which shown that the prevalence in the general population of bulimia nervosa is about the same, whether you're using the slightly broader criteria of ICD-11, which allow for subjective binge eating, or the DSM. But for people with binge eating disorder, you change the prevalence quite a lot by those diagnostic specifiers of the binge, which are not required for a binge in bulimia nervosa. So we end up with these schemes which come from different historical backgrounds, come from different leaders in the field who have been inputting into developing the diagnostic schemes. But to change that is very difficult. And if you ask someone who's involved in developing any of these diagnostic schemes, why is it difficult? Well, there has to be empirical evidence, but also you're changing people's concepts and their understanding. And that is hard, that is challenging. And that's why it's challenging. I think when I read that article by Andrea Phillipa saying, take the weight out, your initial response is, can't possibly be. This is how we understand people with anorexia nervosa are clinically underweight. This is what it is, So changing conceptualization of disorders is difficult and challenging and takes time. But I would hope in the future, sort of vision that when they redo diagnostic schemes in eating disorders, they do a whole rethink and think of what are the core features of someone with an eating disorder, and then how that might manifest in different ways. I think, to be fair, from the genetics, there is likely to be different manifestations of eating disorders, one that is perhaps more associated with heritability of leanness, and one that's more associated with heritability of being higher weight, one that's more associated with clinical perfectionism and some other personality styles that may drive that, and both sort of predisposing but also perpetuating for a disorder of high levels of dietary restriction, and people with other personality styles.
Phillipa, as you describe the evolution of your thinking and the ways in which we could evolve our diagnostic systems, as you look at what you've learned, what would be some of the things that you hope you could pass to the next generation of researchers, opportunities for future studies, future learnings that would continue to advance the field?
Well, I think to be open to rethinking the diagnostic schemes, much more informed by what we're learning in terms of the genetics, in terms of the risk factors, in terms of understanding people who develop eating disorders, on profiles that are related to psychological profiles, genetic profiles, biological profiles, that then better inform treatments. We're seeing many people coming for treatment with eating disorders with complex trauma, emotion dysregulation, high levels of negative affect. We really need to be thinking about them as people who may need more specific treatment needs that are not necessarily encompassed in the standard treatments that we're offering at the time. As with someone who is very low weight or in a clinical state of starvation, we do tailor our treatments to renourishment. We should also be tailoring treatments to thinking about the person in terms of broader aspects of who they are, how they perceive themselves, other psychopathologies.
Terrific. So last takeaway, You have really an illustrious career, have worked across clinical services, across diagnostic conditions. What's one of the things that you might have hoped that at this stage in your career we would have solved already?
I would hope we'd have solved the treatment gap. I think we are solving it, but it's still there for many people. I think there's still high levels of stigma and high levels of barrier to people both recognizing that they have an eating disorder, but in healthcare professionals recognizing they have an eating disorder. And that again is where the focus on weight is so pernicious, because many healthcare professionals still, and I hear people tell me, look at you and say, you're not underweight. You can't have an eating disorder. So I think we're getting there. I think there have been, major changes happening. I think people with eating disorders are now accessing treatments that they wouldn't have accessed even 5 years ago, 10 years ago. And particularly people who are in the higher weight range who have been told that their problem is just weight and nothing else. And I know that there have been a lot of movements to recognize that eating disorders occur in people at all weights, and no matter what your weight is, there is treatment and treatment that is effective. So I think it's happening, but I would really like to see it close and to see the majority of people with eating disorders being enabled, being empowered to access the treatments that we know will be helpful, and that will also, alongside that, obviously driving the development of treatments, finer tuning of treatments, precision medicine, I think is what it's called. So personalizing your treatment with the individual in the room. And if they have complex trauma, then using what we know about complex trauma to assist them, as well as what we know about changing eating disorder behaviors.
Well, Phillipa, you have contributed so much to closing that gap in so many ways, and really appreciate your sharing your experience and your big idea. So thanks for joining us.
Thank you, Kevin.